This was the first in a 4-part series on infectious pulmonary diseases. We're going to start with pneumonia. Pneumonia. A cross-sectional view of alveolar consolidation in pneumonia. At the bottom, you can see alveolar consolidation, leukocytes, macrophages, red blood cells, and type 1 cells. Pneumonia or pneumonitis with consolidation is the result of an inflammatory process that primarily affects the gas exchange area of the lung, or the alveolar capillary area. This process of fluid transfer is called effusion. Inflammation, fluid serum, and some red blood cells from adjacent pulmonary capillaries pour into the alveoli. Polymorphonucleic leukocytes move into the affected area and engulf and kill invading bacteria on the alveolar walls. This process is called surface phagocytosis. Increased numbers of macrophages also appear in the infected area and remove cellular and bacterial debris. If the infection is overwhelming, the alveoli becomes filled with fluid, red blood cells, and polymorphonuclear leukocytes and macrophages. When this occurs, the lungs are said to be consolidated or have consolidation. The major pathologic and structural changes associated with pneumonia are inflammation of the alveoli, alveolar consolidation, and atelectasis. Atelectasis is seen especially in aspiration pneumonia. So let's talk a little bit about who gets pneumonia and how it happens. So pneumonia and influenza combined together are the 8th leading cause of death among Americans and the 6th leading cause of death for Americans over the age of 65. It's estimated that about 50,000 Americans die of pneumonia each and every year. Pneumonia and influenza are especially life-threatening in individuals whose lungs are already compromised by COPD, asthma, or smoking. The risk for death from pneumonia is also high among people who have heart disease, diabetes, or a weakened immune system. Pneumonia is the leading cause of morbidity and mortality for children that are just beyond the neonatal period, or just a little bit older than 1 month old. It accounts for an estimated 900,000 deaths, not quite 1 million deaths worldwide, and its effect on outpatient visit rate is extremely high. The chest X-ray, which is often used as a clinical reference standard to guide management, does not differentiate viral or from bacterial disease or predict clinical course, particularly in small children. Causes of pneumonia include bacteria, viruses, fungi, protozoa, parasites, tuberculosis, anaerobic and aerobic organisms, aspiration, and the inhalation of irritating chemicals such as chlorine. Pneumonia is an insidious disease because its symptoms vary so widely. Depending on the patient's underlying condition and the type of organism causing the pneumonia, it can look very different. It often mimics a common cold or flu. For example, the patient may suddenly experience chills, shivering, high fever, sweating, chest pain, which is called pleurisy, and a dry or non-productive cough. Often, what initially appears to be a cold or the flu can in fact be a much more serious lung infection or pulmonary infection. The earlier you recognize and treat pneumonia, it provides the best chance for a full recovery for the patient, especially in the elderly or the very young. The terms bronchopulmonary, lobar pneumonia, and interstitial pneumonia refer to anatomic location of inflammation. Bronchopulmonary pneumonia is characterized by a patchy pattern of infection that is limited to the segmental bronchi and the surrounding lung tissue. Bronchopulmonary pneumonia usually involves both lungs and is seen more often in the lower lobes of the lungs. Lobar pneumonia is involvement of the entire lung. It's widespread or diffuse alveolar inflammation and consolidation. Lobar pneumonia is typically the end result of severe or long-term bronchopneumonia, and it's spread from one lung segment to another until the entire lung lobe is involved. Interstitial pneumonia is usually a diffuse and often bilateral inflammation that primarily involves the alveolar septa and interstitial spaces. Double pneumonia is involvement of both lungs. In contrast to alveolar pneumonia caused by bacteria, the polymorphonucleic leukocytes do not migrate into the alveoli but remain in alveolar interstitial spaces. Typically, mycoplasmic pneumonia and some viruses cause interstitial pneumonias. Fortunately, most interstitial pneumonias cause only minor permanent alveolar damage and usually resolve without much consequence. Although the lay term is walking pneumonia, it has no clinical significance and is often used to describe a mild case of pneumonia. For example, patients infected with mycoplasmic pneumonia, who generally have mild symptoms and remain ambulatory, are sometimes told that they have walking pneumonia. Let's talk about some of the causes and classifications of pneumonia. Some of the bacterial causes include gram-positive organisms, both Streptococcus and Staphylococcus. We'll take a look at the difference, the microscopic presentation of staph and strep and gram and bacilli and what they look like. Community-acquired Typical pneumoniae include Streptococcus organism, which is a gram-positive coccus that is pictured here. It occurs singly in pairs and in short chains, which you can see in this picture. Another community-acquired typical pneumonia is mycoplasmic pneumonia, though that's not pictured. The Staphylococcus aureus can be a community-acquired or hospital-acquired organism. It's a gram-positive non-motile coccus, which just means round, and it's found singly or in pairs, and it's in irregular clusters. They almost look like a cluster of grapes. This is how you can show the difference between strep and staph. Strep looks like a string of pearls. Staph looks like a cluster of grapes. Strep, community-acquired. Staph, generally hospital-acquired or community-acquired. Other community-acquired are Haemophilus influenza, Legionella, Enterobacter or Klebsiella. Klebsiella looks very currant jelly-like. Moraxella, and Pseudomonas aeruginosa, which is also on the surface all over hospitals. Gram-negative organisms include Haemophilus influenza, Klebsiella, Pseudomonas, all over the surface of hospitals. Moraxella cataharis, E. coli, which is from poo, Serratia series, and Enterobacter, again poo. Washing hands will help after you go to the bathroom. These bacilli are rod-shaped microorganisms and are major gram-negative organisms responsible for pneumonia. You can see the rod-shaped here. Please look for a full list. Please look at box 18.2 on page 282 of your book. Let's talk about a few of the atypical pneumonias. Clinical presentation of a patient with community-acquired atypical pneumonia is often subacute. It's not as bad as one you'll see in the emergency room. Common causes of a community-acquired atypical pneumonia are tiny cell wall deficient organisms like mycoplasmic pneumonia. They're smaller than bacteria but larger than viruses. The pneumonia caused by a mycoplasmic organism is commonly described as a primary atypical pneumonia. The term atypical refers to the fact that the organism escapes identification by standard bacteriologic tests. There's generally only a moderate amount of expectorated sputum. There's an absence of alveolar consolidation. There's only a moderate elevation of white blood cell count, and there's a lack of alveolar exudate. The mycoplasmic organism causes symptoms similar to both those of bacterial and viral pneumonia. And although symptoms develop more gradually and are often milder, chills and fever are early symptoms. The patient typically presents with a mild fever and patchy infiltrate changes in the lungs that are mostly confined to the alveolar septa and pulmonary interstitium. Common symptoms are a cough, and it tends to come in violent attacks producing only a small amount of white mucus. Some patients experience nausea or vomiting, and in some cases, patients may experience a profound weakness that lasts for a long time. It can be a month to 2 or 3 months. Mycoplasmic pneumonia is commonly seen in children and young adults. Typically, this kind of pneumonia spreads easily where young people congregate, such as dorms, college dorms, or a crowded pool, any crowded social area, homeless shelters, schools, colleges. Patients with this type of walking pneumonia have a slight fever, fatigue, and a hacking cough. Another type of atypical pneumonia is the Coxella burnetii pneumonia. It's a gram-negative bacterium that causes a fever in humans. It's more resistant than other Rickettsia pneumonias and may be passed from infected human aerosols and in living animals such as cattle, sheep, goats. And acute pneumonia and chronic endocarditis are also associated with this. Another atypical pneumonia is a chlamydia species pneumonia. This closely resembles clinical manifestations of those found in the cervix, urethra, rectum, and throat and respiratory tract. Chlamydia is also found in the feces of birds, parrots, parakeets, lorikeets, cockatoos, pigeons, ducks, pheasants, turkeys. The clinical manifestations of this chlamydia pneumonia closely resemble those caused by M. pneumoniae. Viruses also account for about half of all pneumonias, and several are associated with community-type acquired atypical pneumonia. Although most viruses attack the upper airways, some can produce pneumonia. Most of these pneumonias are not life-threatening and last only a short time. Viral pneumonia tends to start with flu-like symptoms. The early symptoms are dry, non-productive cough, headache, fever, muscle pain, and fatigue. As the disease progresses, the patient may become short of breath, cough, and produce a small amount of clear white sputum. Viral pneumonia always carries the risk of developing a secondary bacterial infection. Viruses are minute organisms and aren't visible to ordinary light microscopy. They are parasitic and depend on nutrients outside of cells. About 90% of acute upper respiratory tract infections are caused by viruses. Some of the viruses include influenza virus, respiratory syncytial virus or RSV, parainfluenza virus, adenovirus, and coronavirus such as in SARS. As we know, COVID-19 is a serious viral cause of pneumonia. Other causes of pneumonia: Rickettsia infections, varicella, rubella, aspiration pneumonitis from various causes, including GERD, silent aspiration, and obstruction and toxic injury, pneumocystis carinii and cytomegalovirus, tuberculosis, fungal infections, and avian influenza. Let's talk a little bit about how and where you can get pneumonia. The clinical presentation of where and how you get pneumonia is important. So acquired pneumonia classification just means, where did the pneumonia come from? If you got the pneumonia at home or out in the community, it's called a community acquired pneumonia. If you got the pneumonia in a nursing home or a subacute facility, it's called a nursing home acquired pneumonia. A hospital acquired pneumonia or nosocomial pneumonia is defined as a pneumonia that occurs within 48 hours or more after hospital admission and was not present at the time of admission. In general, the most important pathogens are Pseudomonas aeruginosa, methicillin-resistant Staphylococcus aureus, and methicillin-sensitive Staphylococcus aureus, or MRSA. Enterobacter and E. coli and Serratia are also hospital-acquired pneumonias. Healthcare-associated pneumonia refers to patients who have recently been hospitalized in acute care within 90 days of infection and who have resided in a nursing home or long-term care facility, or who have received IV antibiotic therapy, chemotherapy, or wound care within 30 days of pneumonia. Common pathogens for this include a mixed aerobic and anaerobic mouth flora, S. aureus, enteric gram-negative bacillus, influenza, and M. tuberculosis. Ventilator-associated pneumonia, or VAP, also called ventilator-acquired pneumonia, can be all included under a nosocomial pneumonia category. VAP is associated pneumonia that develops more than 48 to 72 hours after an intubation and endotracheal intubation. Common VAP-associated agents are Pseudomonas aeruginosa, Enterobacter, Klebsiella, Acinetobacter, Stenotrophomonas, and S. aureus. Concern that the occurrence of VAP is preventable lies as the root of possible reimbursement penalties for hospital when it occurs. Let's review clinical manifestations associated with pneumonia. The following clinical manifestations result from mechanisms caused or activated by pneumonia: alveolar consolidation, increased alveolar capillary membrane thickness, atelectasis, excessive bronchial secretions, which is during the resolution stage of pneumonia. What will you see at the patient's bedside? Increased respiratory rate, tachypnea, increased heart rate, and increased blood pressure. Chest pain, especially with cough, decreased chest expansion or splinting, possibly cyanosis, which is a late sign of hypoxemia, cough, sputum production, and hemoptysis. Sputum production can be anywhere from white or clear all the way to purulent or current jelly-like, depending on the organism. The physical exam. Chest assessment. Increased tactile fremitus and vocal fremitus, a dull percussion note over the area of consolidation, bronchial breath sounds over the consolidation, crackle and rhonchi where the consolidation is, rhonchi in the bronchi, pleural friction rub if the process extends to the pleural surface, and whispered pecaliloquy. Laboratory tests and special procedures. For the most part, people with a pneumonia are not able to do a pulmonary function test. They're too sick. However, you should know that a moderate to severe pneumonia mimics a restrictive lung pathology. Flow rate findings are a restrictive pattern. Flow rates should be normal or may be diminished. Lung volumes and capacities, again, mimic a restrictive lung pattern. Tidal volume will be normal, and volumes and capacities will be normal or diminished, depending on the severity. In acute ventilatory failure with hypoxemia, in severe pneumonia, you will see an acute respiratory acidosis, which means the pH will be low, the PaCO2 will be high, you will have a normal bicarb, and the PaO2 will be low. On chest x-ray, and we'll look at several chest x-ray, you may see an area of patchy infiltrate or consolidation, atelectasis, air bronchograms, and pleural effusions. This chest x-ray is of a 20-year-old woman with severe pneumonia of the left lung and patchy pneumonia in the right, middle, and lower lobes. So, as you can see, the left lung there's a patchy pneumonia in the right, middle, and lower lobe, and severe pneumonia of the left lung. This is an air bronchogram. You can see the patchy infiltrates. The only air you can see are in the bronchus. So they're clearly outlined through the infiltrates. You can see the branchial linear lucency, the dark lines of the bronchus. in the consolidation. This is a staphylococcal pneumonia. Let's look at a CT scan with alveolar consolidation. So here are air bronchograms clearly delineated in a CT with a big consolidation. So how do you manage pneumonia? You treat the underlying cause. You treat the symptoms in a viral pneumonia or mycoplasmic pneumonia. Antimicrobials or antivirals, hydration, cough medicine, and possibly oxygen and a ventilator if needed. Use oxygen therapy protocols, bronchopulmonary hygiene therapy, lung expansion therapy to treat any atelectasis, and bronchodilators as needed if the patient has other comorbidities. Thank you. We've come to the end of the presentation. I want to leave you with a final thought: to live out of your imagination and not your history.